Today I am going to take a lecture on mental health interventions in India. After I finish my lecture, you will be in a position to know about the policies and programs launched by the government for mental health care. You will also learn about the various intervention programs, identify the problems faced in launching mental health intervention programs, and also evaluate how effective these intervention programs are. So let's start with an introduction to mental health intervention programs. Mental health is a psychological state of being mentally well, that is, free from any kind of mental illness, in which an individual is able to use his or her cognitive skills and emotional capabilities to meet the ordinary demands of everyday life to function normally in a social setting. It can be interpreted, in other words, that that mental well-being is that the person who is functioning at satisfactory level of emotional and behavioral adjustment to cope with day-to-day hazards, normal stresses of life, hassles, enjoy a life and create a balance between life activities and efforts to achieve psychological resilience. Intervention is the act of interfering so as to modify any problematic situation or thing. In case of health interventions are the methods to modify or alter the causes of diseases, that is the measures that are taken to improve health. Mental health intervention programs are those programs which are launched with the purpose of spreading awareness among people regarding mental health issues which are largely neglected by people in India and become the cause of many other stress-producing life events and give birth to many physiological problems too. Now, these intervention programs help in finding mental health problems at grassroots level and then giving early treatment to these problems. I am going to go on to the government policies for mental health intervention first. India accounts for 15% of the global population and 1/3 of the world's poor. In 2009, more than 200 million households were described as living in absolute poverty in India. Emotional distress and depression, manifested mainly through somatic symptoms, are strongly associated with poverty, especially in developing countries. Community and clinical based studies in India have shown that women are twice as likely to be affected by depression as men. There are a number of potential factors for this increased gender vulnerability: poverty, social class, marital and childbearing roles, lack of education, and social oppression. However, most of these morbidity is unrecognized and untreated. Women tend not to seek help because of the stigma that is involved, or because of poverty, or simply a lack of awareness and lack of access to care. Even when women are able to access care and are prescribed antidepressant medication, they drop out of treatment due to the side effects of medication and the costs of continuing treatment. Thus, psychological distress poses a major economic burden on poor women and adversely impacts their livelihoods. Counseling, coping techniques, and breathing exercises are found to be useful in the management of depression in the community. However, individual interventions are resource intensive, especially in developing countries where trained mental health professionals are few in number. The National Mental Health Program, NMHP in India, concerned with the delivery of basic mental health services, has mainly focused on severe mental disorders The treatment of depression, especially in rural communities, has largely been neglected. Government has launched programs like National Mental Health Program and National Rural Health Program that have been a little effort so far as to provide mental health services in India. This work has been launched by NGOs at a bigger level as compared to the government efforts to provide and spread awareness among people regarding mental health services. The Ministry of Health and Family Welfare in India appointed a mental health policy group in April 2011 to frame a new national mental health policy and plan. The centre's co-director, Professor Vikram Patel, was part of this group along with 10 other individuals from diverse backgrounds including the mental health professionals, user and caregiver representatives, public health experts and senior officials of the ministry. And the focus of this report was on the given topics which I am going to tell you now. District Mental Health Programs, DMHP, started with 4 districts in 1996-97 and now they widely cover 123 districts in the 11th 5-year plan. The program envisaged decentralized community-based approach to the problem, including, I am going to tell you the following. Number 1, training the mental health team at the identified model institute within the state. For example, Gujarat Forensic Science University is opened recently to provide a new team of well-trained psychologists, psychiatrists and forensic experts to work for the betterment of Indian society. Secondly, spreading awareness among mental health problems and effective health-seeking patterns. Next is adequate provision of services to promote early detection and treatment of mental illness in the community itself with both OPD and indoor treatment and appropriate follow-up measures. Fourthly, collective data and experiences for future planning research and improving service provision. Fifthly, focus on lack of public health and technical capacity, inadequacy of technical support provided by the ministry for implementation of the states and individual DMHP districts. And sixthly, technical support includes a range of input from establishing a mental health information system to human resource planning and to implement clinical management protocols. Moving on to the shortcomings of the policy. In absence of uniform guidelines, the whole project is interpreted differently in different states. There is a lack of clarity of the goals of the district mental health programs. Thirdly, there is a shortage of funds and required drugs for treatment of mental illness. And then there is a lack of required number of mental health practitioners. Let me give you a brief information of the government policies for the mental health care in India. In 1969, Mudaliar Committee recommendations on mental health were there. In 74, Srivastava Committee recommendation of community health volunteer known as CHV includes mental health in scope of work. In 1975, training of general practitioners in psychiatry started at NIMHANS. In 1976, need of rural population studied by NIMHANS in one primary health center. From 76 to 81, Raipur Rani project as part of WHO multi-center project on strategies for extending mental health care. From 1980 to 86, there was a pilot experiment to integrate mental health into primary health care at one primary health care center of population of 1 lakh at selected talukas of Bellary district. Again from 82 to 84, the ICMR, which is the Indian Council of Medical Research project at 3 sites test out the NIMHANS material for training of general practitioners in psychiatry. In 1984, the Bellary model up scaled to entire Bellary district. In 1985 to 1990, DMHP pilot test it at Bellary district. From 85 to 87, ICMR project, mental health in PHCs, that is public health centers at Solur, Karnataka. In 1987, ICMR had a Department of Science and Technology project at 4 locations in the country, had a collaborative study on severe mental morbidity. In 1995, there was a meeting of Central Council of Health. In 96, recommendations of starting mental health programs at a workshop of all health ministries in Bangalore. In 96 and 97, DMHP launched in 4 districts of the country. 1997, Quality Insurance in Mental Health Care Services reports by National Human Rights Commission. From 1997 to 2000, phased expansion of DMHP districts. In 1999, mental health agenda of World Health Organization set, MH identified as priority for WHO's work. 2001 was World Health Day theme based on mental health. In 2001 itself, WHO report with focus on mental health was implemented. In 2003, World Health Survey involved 5 states, and 2007 to 8 DMHP in 123 districts. 2008 to 9, evaluation of DMHP by Indian Council of Medical Research in 20 out of 127 districts. In 2011, a review of 23 districts in 4 southern states of DMHP was conducted by NIMHANS. 2012, WHO Executive Board adopts a resolution which was proposed by India in US and Switzerland on coordinated health and social sector response to mental health problems. Let me go on to the models of mental health care and services in rural areas. The different models that are present are at different institutional levels, like for example at institutional level, personal level, and at state level or district level. All the models are the structural representations of the required availability of mental health care in India. Intervention programs for mental health care in India should be distributed in the form of the models at large scale so that maximum population should be covered by providing mental health care. Let me talk about some of the mental health care intervention programs which were launched by NGOs. These are case studies. DMHP's awareness programs help people seek early treatment. District mental health programs with the aim of providing mental health care services with physical care services, healthcare services, has launched an intervention program at community level to spread awareness among the people of community regarding mental illness. The program was launched in Kattikal Grama Panchayat of Kerala and Kalikadu and Churinur Gram Panchayats of Karnataka. A team of trained social work students and students of psychiatric nursing were camping in Grama Panchayatas of Karnataka and Kerala to conduct mental health awareness programs, including a medical camp in the end of the program, where people are encouraged to seek professional assistance for any problem that they may face. 3-member teams of trained accredited social help activists, that is the ASHA or Anganwadi workers, visited every house in every ward, met families, and with their help filled out simple questionnaires that help identifying certain general symptoms of mental disorders. Though 322 cases were identified, only 89 attended the medical camp. Anyhow, there were many benefits of this camp. Some of them are that new cases of mental health issues can be picked up at grassroots level, and the treatment of these cases at early stages was possible. The stigma of mental illness continued to be a huge hurdle, but many gram panchayats have been showing interest in implementing the program. The hurdle can be removed by launching more and more such camps to spread awareness among people regarding mental health issues. Pathway of care among psychiatric patients after a mental health institution in central India. Only a limited proportion of patients with psychiatric disorder attend the mental care facilities, and that too when condition becomes very severe. Treatment from unqualified medical practitioners and faith healers is a common practice in India and is attributable to the delay in proper treatment. A cross-sectional study was conducted to understand the pathway of care adopted by psychiatric patient and its relationship with the socio-demographic determinants in the study population. The subjects were selected from urban specialty psychiatric hospitals and intervention used pre-tested semi-structured intervention schedule. The data was analyzed using SPSS 10 software, chi-square test, t-test and Kruskal-Wallis test were used as needed. A total of 295 patients, out of which 203 were males, were included in this study. The majority of patients, 45%, were suffering from bipolar affective disorder, followed by schizophrenia, which was about 36%, and the majority, 203, which is 68%, were from rural India. The majority of this had first contacted faith healers, almost 69% of them, and a qualified psychiatrist was the first contacted person for only 9.2% of the patients. Now the conclusion is, a large proportion of psychiatric patients do not attend any health facility due to lack of awareness about treatment services, the distance, and also due to the fear of stigma associated with treatment. The psychiatric patient first seeks the help of various sources prior to attending a psychiatric health facility. Moving on to the availability of mental health care center in India in different states. Almost all the states have DMHPs available for mental health care, but these DMHPs are available in few districts only. DMHPs are slow exercise for launching mental health intervention programs, but still it is effective and need to be spread out in different regions of India. Next, I am going to talk about the availability of mental health services. We have found that the mental health care facility in different regions of the country, the states with dense population and with larger size only have 2 DMHPs available. Few states don't have DMHPs available, and most of the states have only one or at least one DHP available for taking care of mental health issues. Let me summarize what I have taught you today. Number 1, mental health is a psychological state of being mentally well. When I use the term mentally well, I mean free from any kind of mental illness in which an individual is able to use his or her cognitive skills and emotional capabilities to meet the ordinary demands of everyday life to function normally in a social setting. Mental health intervention programs are those programs which are launched with the purpose of spreading awareness among people regarding mental health issues which are largely neglected in people in India and become cause of many other stress producing life events and give birth to many physiological problems too. Because as we all know that mental health and physical health are closely related topics. In 1982, National Mental Health Program, NMHP as it is known, was launched. And since then, it is taking care of delivery of mental health services provided all over India. But it is mainly focused on severe mental disorders. The treatment of depression and stress, especially in rural India, is still largely neglected. Government has launched programs like the National Mental Health Programs and National Rural Health Programs that have been small efforts from the side of the government so far to provide mental health services in India. This work is being taken up by the NGOs at a much bigger level. So if we compare the NGOs with the government efforts, we find that the NGOs are doing much more to provide and spread awareness among people regarding mental health services. I have also talked about the model of mental health care services in rural India. Here I have talked about the institutions, personal, state level and the roles that they do. If we talk about institutions like mental health institutions, at the personal level there will be a specialist, there will be institutional care and services, the level would be the state level and the role would be treatment of severe mental health disorders. Institutions, if they are district health society, at the personal level there will be a civil surgeon, level again would be district level. Role would be planning, implementation and service delivery. If the institutions are community health center, at the personal level would be a psychiatrist. Level would be about 1 lakh population and the role would be treatment for common mental health disorders. At the primary health center, the level at personal level would be a medical officer in charge. The level would be a block, say about on 30,000 population, and the roles that they would be doing would be that of counseling, identification, referral services. If you move on to the community care, at the personal level would be ASHA, which is the accredited social health advisor. The state level, the level would be the village or the community level. And the roles would be care, support, education, acceptance and in addressing stigma or discrimination. Moving on to the institution of self-care or family care. At the personal level would be the family or the community members. The level of course would be family and the role would be that of care. I have also talked about a case study in which I told you about the role of panchayats and the benefits of the camp. Though the benefits were quite small, yet not negligible. This camp helped in picking up cases at the grassroots level and treatment of these cases at the early possible stage. Stigma of mental illness continued to be a very big and a huge hurdle at this level, but many gram panchayats have been showing interest in implementing the government programs and also the programs that are launched by NGOs to help people become aware of mental illness issues.